So a 53-year-old guy that previous history of L4 laminectomy 20 years ago. He has a chronic left foot drop, but a 6-month history of progressive and urgent claudication, radiculopathy, and a left L3 pattern. He now can't walk over 100 feet. He has severe left L3 pain primarily, and he's failed conservative management. He does not want injections. Doctor, didn't work in the past. I'm not doing that. You need to fix me. So here's his x-rays. Really nothing much to show here. No big deformity, lots of spondylosis. And really, this was all about this 2-3 disc herniation here. And so, you know, I thought, well, shoot. This was his previous 4-5 decompression. And so I thought, well, you know, let's just do a simple little micro decompression, which, you know, gosh, that's simple, right? Who has a problem with that? So what are the options? No surgery, decompression, what levels, do you do a fusion and all that? I mean, I think everybody can kind of agree that if it's primary radiculopathy, let's just take care of the radiculopathy. So that's what we did. L2-3 MLD initially did well, but 7 days post-op, draining wound and fever. Now, I will say that our physician-owned hospital, our infection rates are below 1%. They track somewhere between 0.6 and 0.8. So we have a very fortunate, clean facility, but this guy, not so much. And here's our MR. So epidural abscess, as we can see here, compressing the thecal sac. Bad news, you know, what do you do there? So we IND'd, we closed primarily. You know, do you do a wound vac? Do you do a drain? I mean, what would people do for that? What would people typically do for that? Would you just IND it, and if it all looked good, close over a drain, or would you consider leaving it open and doing a wound vac? Who's kind of for just IND, and if it all looks good, closing it up? Put them on IV antibiotics, look for the bug. Put a drain in. No, we put a drain, yeah. IND, put a drain, wait for the drain to come down, post-operative antibiotics, treat the bug that you find. Okay, that's what we did. So we closed over a drain. It was MSSA. 6 weeks of antibiotics, and 6 weeks post-op, he was actually doing pretty well. But 14 weeks post-op. Now, again, this is, a lot of times these happen a couple of weeks after the stop antibiotics, but he's 14 weeks post-op. He's back in the ER with severe back pain, and he can't ambulate. Now, this is what we got. Okay, so look carefully at the disc space and the end plates, kind of where we see the infection in the epidural abscess. So now he's failed once, and so now let's talk about what we would do at this point. Options? Thoughts? Sig, go ahead. I'm putting you on the blind.
Yeah, so I think this is an epidural abscess with somebody with a neurologic deficit. He can't ambulate. I don't know if it's weakness or pain, but
weakness and pain.
But this is a neurologic deficit, and to me, this is something I'd rather treat early. You know, Jens Chapman has an algorithm for how do we avoid the late consequences of infection, and I'm going to treat this pretty aggressively. In my hands, I'm going to go with the direct lateral, do a complete discectomy, try and evacuate infection there. I was impressed by Dan yesterday talking about doing this endoscopically, which is interesting. But yeah, I'm probably going to treat this more aggressively. I'm going to do a complete discectomy, debride that interbody space, and then go posteriorly. And in my hands, it looks like you've already done a midline laminectomy, but there's so in my hands, I'm going to open this up in the back as well, and just widely wash this out and infuse them in the back as well.
So you're going to do a fusion in interbody?
Yeah, I'd go straight to a fusion.
Okay.
I would not. I would not do that.
Yeah? Yeah, he's got a little extension into the psoas. I think, I'm not sure if that's really abscess or inflammation, but yeah. So we did, in his first washout, I did a more aggressive laminectomy at L2, but only L2. So when you see, so I really didn't go down to L3-4. So, but as you can see in this, I did increase his laminectomy during his washout just to make sure that I got reaching into the neuroforamen and washing him out and that type of thing. Yeah, so anyway, let's go to what, Rick, you were going to say, no, don't do a fusion. What would you do in this situation?
I would redo it posteriorly.
Okay,
I would do an aggressive discectomy.
yeah,
I would leave a drain in the wound that I can use for irrigation.
yeah,
And then I would put in a PICC line and put him on long-term antibiotics.
okay. Any other thought? Yes.
Obviously, reculture in the old Santé feed-me, drain-me protocol has served me well over 29 years. I never had to refuse or fuse anybody in the situation. I had several, and sometimes it's a bug that you miss. But just starting that person on some kind of intra-wound antibiotic with a drainage system, and then changing the antibiotics, pending the new cultures. And, that has served me well over that.
But still a washout, no fusion.
Oh, yeah, washout, no fusion.
Bob?
Yeah, well, one of the things I've always done when I suspect an infection and I get a CRP, and if the CRP is elevated, I always switch the antibiotic from whatever it was as a prophylactic that we used in the perioperative period. But in this case, you treated him for 6 weeks. I wouldn't have taken him off antibiotics without checking the CRP to see that it's reasonably low, if not normal. And if the patient was symptomatic at all, or
He
had
wasn't. At 6 weeks, he was doing awesome.
or had an elevated CRP that was going up on sequential ones, or was just pretty dang high in the first place, I would have gotten an MRI to see if I had a fluid pocket, a seroma, whatever it was. Then I would have aspirated that to see what that was.
Yeah, I think that's a good thought. I mean, I would have gotten a CRP if he was still mildly symptomatic and may continue the antibiotics at 6 weeks. That was sort of the time, but he was doing really well, and so we took him off. But that's a good point. So, that is the issue. So what happened was actually, I was leaving town the morning he showed up, and so you hate doing that to your partners, but Dr. Kerr took him back, and it was just terrible. It tracked to L3. He performed full laminectomies at L2 to redo there. Now L3. He got a dural tear, primarily repaired it, put a drain, 6 more weeks of antibiotics. These were, I think we used dual therapy on him. And then 2 weeks post-op, he was greatly improved. 3 weeks post-op, he had some mild wound drainage. We sent him to wound care and hyperbarics. 5 weeks post-op, he had increased severe back pain and fever. Now, this is how he shows up. So now look at his vertebral bodies at 2 and 3. He's now got an epidural abscess now at 3-4 from that previous laminectomy. And now look at his CT and his end plates here at L2. So now what do? I know what Sig's going to say, but let me ask you this, Sig. Are you just going to do 2-3 at this point? Because he's got an epidural abscess now at 3-4.
That's a really important question. I think this is what we want to avoid. Obviously, is the end plate changes, or in some cases, much more progressive deformity. In this case, no question, this is again an interbody fusion, and I prefer to do this from a lateral. A lot of times, this will have a concurrent psoas abscess, as JJ pointed out, and I feel like I can take care of that. Now the question is, what about 3-4? It looks like there's some motor changes there, but I want to make sure that that's not infected. I don't see fluid in the disc at 3-4. In the absence of infection in the disc space, I'd probably stick with 2-3, and again, revise the decompression from the back, widely decompress, but try and keep the instrumentation to the area that's actually infected.
Rick?
I would do the same thing I just did, long-term antibiotics. Let me give you I had a case. How old is this guy?
He's 58.
Okay, so he's young. I had a case that is sort of like this, but he was 80 years old. He was referred to me by Ivan Shurik, who's a famous neurosurgeon that everybody knows. This guy was an obstetrician. He delivered every baby on the North Shore, so very well-known guy. Everybody in his family is a doctor or a lawyer. He's already had 5 operations for horrible 2-level osteomyelitis, completely bedridden, completely debilitated. So I was talking to the family and I said, if we do what we really need to do to clean this up, which is a 2-level vertebrectomy, he's going to die. He will not tolerate that operation. So I said, let's just do long-term antibiotics and let's send him to hospice, which we did. Family wanted to do that. So wife calls me 6 weeks later and says, when's he going to die?
Yeah, so
A year later, Ivan Shurik calls me on my phone and says, Rick, I'm at Ravinia. Guess who's with me? So by not operating on him and not killing him, I gave him his life back.
no, and I think on the individual case that's really good. But I will tell you the rest of the story. So back here, so I show up Monday morning, patient still in the hospital, and Kurt tells me what he's doing. The patient's doing well. We're getting ready to discharge him, and all of a sudden Peter Campbell comes around the corner in his typical way. He goes, well, that needs to be fused. And I'm like, well, why? He says, you got an infection. You got to stabilize it. I mean, come on. This is 101. You got to stabilize this. So I then went, it's great having great partners that are smart. I went to each partner and I said, what do you think? And they gave the Rick answer. And I have one that was vehement about you should fuse him. And so he said he's going to be back. He's going to be back. So you either fuse him now, you fuse him later, whatever. So, Dr. Campbell was right. He was 1 out of 4, but that 20% vote wins. So what I did was I didn't want to have Groundhog Day happen again. And so the thing about do I do 3, 4 or not, I was just, hell, I'm just doing it. And so he's destabilized. He didn't even have a facet in the back. Kurt took his entire 3-4 facet off, which I didn't say either. He was unstable in the back. And so I did that, and sure enough, this is the first time, and I hope the only time, that I'm doing my dissection through the psoas with my right angle retractors, and yellow pus just comes out of the psoas. I'm going, God, this is terrible. I hate this case. But anyway, so that's where we are. 6 more weeks of antibiotics, 6 weeks post-op. He's better. Before the index procedure, even 6 months previous. He's now, as we speak, about 3 months post-op. And, we talked about whether we leave the PICC line in and wait for the other shoe to drop. And the our ID guy said, no, get the PICC line out because I don't want that to be the nidus of infection that leads into the next thing. So go ahead and get the damn thing out and let's just, he didn't. I said, well, what about long-term antibiotics? He said, no, you've got stabilization, you should be good.